Welcome. I'm John Bagnulo, and it's great to be with you this afternoon to discuss protein requirements in different populations that may need to be adjusted. I guess like to some extent, there is growing evidence in this, but we're really talking about the optimal amount of protein required to improve outcomes. And it's great to be with you. It's been a while. This is a topic that I find fascinating on so many fronts, and it's the first of a two-part series on protein. In a few weeks, we'll have a discussion on protein quality, but we're going to really take a more quantitative approach this afternoon. And I have four objectives for us this afternoon. The first is I would like everyone that participates to be able to identify those populations where there is at least a increasing body of evidence that greater protein requirements are warranted, and we'll discuss those in detail. I think it would also be great for participants to be able to explain why it is that with the aging process and in certain conditions, what are those metabolic changes? Why are there higher levels of protein required for optimal outcomes? A lot of that has to do with kind of cellular physiology changes as we get older, and in certain conditions where there's inflammation and disease states. Third, I'd like to have everyone be able to list the changes in protein requirements that might be necessary to optimize, again, outcomes, recovery, the aging process, and how those would look different than the current RDAs. And lastly, describe how the timing and the quantity of protein at each meal may be as important or more important than the total quantity at the end of the day. And I would like everyone to know that I do serve as the Director of Nutrition for Nutritional Medicinals, who's the manufacturer of Liquid Hope and Nourish, and now a variety of enteral formulas that goes under the brand name Functional Formularies. And I'd like to thank all of you for being with us today, and I would like to thank Functional Formularies for making this opportunity happen for us. I think the best place for us to start that would illuminate the need for maybe adjusting some of our recommendations would be to first discuss sarcopenia. And sarcopenia is really described as a loss of functional muscle mass. I don't want to get bogged down in terms of what that is in terms of a percentage loss in muscle mass from any given age, because there are definitely differences in how it is defined and how it is diagnosed globally. But in general, I think a safe way to describe sarcopenia is when you have a significant loss of muscle mass that compromises quality of life in one way or another. And that quality of life should not be looked at as just a limitation in terms of mobility, having the strength to do things that people need to do in daily life, whether that's taking the lid off of a jar of food, or lifting something like a bag of groceries. I mean, the other ways that we could look at this as really influencing quality of life would be when we lose a certain amount of muscle mass, we're in essence losing what I like to call our metabolic machinery, which keeps us insulin sensitive and really helps prevent insulin resistance. It's a two-way street. Insulin resistance, as you're going to learn in a few moments, really complicates things for older adults and really increases their protein requirements. And at the same time, what makes it almost a vicious cycle is as we lose muscle mass, we're losing, one of those, aspects of our skeletal muscular system, which can help prevent insulin resistance. So the problem gets compounded. Sarcopenia, though, it is one of the top 2 or 3 causes of a loss in quality of life in older adults. And, that's without question. And it can happen, simultaneously with obesity. We have just a growing percentage of our population here in the United States, and it's global, where obesity and sarcopenia occur at the same time in individuals. And that number here in the United States ranges, depends on who you talk to, what reports you look at, studies, but they range from 25% to 45% of the US adult population in terms of who is experiencing sarcopenia. That's a broad range, but we know it's at least 25% of our population, and there are studies and there are clinician surveys which have suggested it's more in the area of 45%. So it's a problem. We know that, and it's really driven by, this is again on the broader topic here of sarcopenia, it is driven by, as we get older, it's driven by a reduction in physical activity combined with a decreased production of our androgens or sex hormones, primarily testosterone. I mean, that's really it's a main kind of rate limiting factor to muscle mass and how much we can carry, but it's not the only determinant when it comes down to androgens. We know that insulin-like growth factor, IGF-1, plays a huge role in helping support muscle mass and bone mass for that matter. And I have to stop myself here, and I know that for the most part we've really just been focusing on muscle mass, but this discussion goes beyond just muscle mass. I mean, that's one that we can all really visualize, and I think we can appreciate the importance of, but I'm talking about lean body mass, and bone mass is a big part of that. And I think it's very important for us as clinicians to always stop ourselves and make sure that with any patient or with any population that we're working with, that we are, whenever possible, doing our best to determine the differences between total body weight or total body mass and lean body mass. And that's going to be really important when we talk about some of these recommendations and some of the research that has been done on protein requirements. When they're able to separate those two, you find very different results for good reason. But when we look at the aging process and we look at how it is that more and more people are experiencing both sarcopenia and obesity at the same time, you can see that that decreased metabolic rate, we're not, which comes first, the chicken or the egg? Is it that there's a reduction in physical activity and a reduction in sex hormones or these androgens, and then because of that we have a reduction in metabolic rate? I mean, that very well may be the case, but nevertheless, once two of those three are into decline, the third usually follows. And we know that people lose androgen production when they lose muscle mass as well. So, again, in many of these cases, these are two-way streets, but the net effect is that you have, at the skeletal muscular level, you have a decreased, what we call overall anabolic action of insulin-like growth factor. You have higher levels of oxidative stress, which comes with inflammation, but it's also a normal part of life. And then there's mitochondrial dysfunction, which I've spoken about on numerous occasions in these webinars. It's a big part of diseases that we see increasing with the aging process. But this is the perfect storm with respect to sarcopenia. And at the same time, we know that more and more folks are insulin resistant, and that really contributes to the obesity side of things. There are several areas of medicine that this has, I think, an enormous impact on this research and maybe tweaking or adjusting some of these protein recommendations. Gerontology, obviously, we know that field is closely looking at macro and micronutrient needs that better serve older adults and that can really improve the quality of life. But orthopedics is a big one. I remember vividly the first nutritional biochemistry class that I had at Texas A&M in my early 20s, and learning that with broken bones, the two most common rate limiting factors at any given age are the protein and vitamin C. at any meal during the healing process. And this is, this is the kind of information that I feel is, it's unfortunately, it's not out there enough. There aren't, I just don't think there are enough clinicians that are familiar with this kind of real core fundamental science behind things like as simple as healing a broken bone. And we know that broken bones appear from all the evidence that's out there to heal at a significantly more rapid rate with higher protein intakes. And I've got some studies that will reflect that. So, I think orthopedics is a big area of medicine that this is very applicable to. And thoracic surgery, in the same breath, we know that the outcomes there are significantly improved with those populations that are able to reach higher levels of dietary protein per kilogram of lean body mass. And then endocrinology, as I mentioned earlier, we know there's a relationship here between protein intake, muscle mass, and how that influences insulin sensitivity or conversely insulin resistance. So, this can really go in a lot of different areas of medicine, which is great because I think that makes it, more useful to so many of us. Here are the questions that I think are most important to ask ourselves in our practice with the patients that we're working with going forward. How is it that my patient's protein metabolism may have changed given their age? We know that, as I mentioned earlier, with the aging process, and once we get into working with older adults, which I would loosely define as, based on all the studies involved in this talk, going to be age 60 and over. How do their protein requirements change? And how do those requirements change with significant either injury, periods of catabolism that often happen with, surgical, periods of surgical recovery, and the loss of lean body mass or bone mass? And that's a big part of this. What are the most common rate limiting factors with respect to protein metabolism and its use for recovery and growth? That's big, and we're going to get to that a little later on. And does the amount of protein consumed at one meal over the course of 24 hours play as significant, or as I mentioned earlier, maybe even a more important role than the total quantity at the end of the day? And what I mean by that is, it more important to get 75 grams at the end of the day, or to make sure that 2 of the 3 meals contain, at least 25 grams? And how do we best assess a patient's true protein needs? I think that's the summary question that, we really are all trying to get to. Now, these are our current protein recommendations. They say ours. I shouldn't speak like that. This here in the United States, and you can see the European ones. And I'll say that the World Health Organization, has the same recommendations as we do in the United States. And for adults, it's 0.8 grams per kilogram of body mass. And I think what's noteworthy here is you see at the bottom, for those age 70 and over, it is still 0.8 grams per kilogram of body mass. And, that's, I think, those are the two areas that we want to try to, if we can, delineate and say, what, there are significant differences here, but let's take a look at the research. And before we do that, let's take just for a moment here, let's talk about how these RDAs were developed. I think that this is something that is often surprising to folks. The acceptable macronutrient distribution range determined, used to determine the amount of protein as well as, carbohydrates and fats, essential fatty acids that populations need, that was set at anywhere from 10 to 35% of kcal. Now, that's a really important point here, because at 10%, the absolute lowest component of that range, that's 50 grams of protein per day. And that's what we currently use. If you ever looked at an NFP, which can be really confusing to folks, regardless of their educational background, an NFP gives us these percent daily values. And that's, what does that really mean? Well, it's basically this: acceptable macronutrient distribution range. And is it acceptable? Well, I don't know as though 50 grams of protein is acceptable for all adults. I think it can be very misleading, but that's 50 grams per day. But that's the lowest level that was established in the research that went into the current recommendations we have. Obviously, if you went with 35%, you're going to multiply that times 3.5. You're in a very, very different place. Now, only 14 individuals over the age of 65 were used in a nitrogen balance study to determine if those over the age of 65 should have higher protein levels. And, again, that's a really, really small sample size. And I think that for all of those protein metabolism experts that are out there, and we're going to talk about folks like Elena Volpe in a minute, this is there's several points that they really take issue with, but these are a couple of them. There were slightly higher nitrogen requirements for this group, but they weren't found because of the small sample size. There wasn't enough power in that group, statistically speaking, to come up with what we call a statistically significant difference. Now, the difference, though, that is really demonstrated is when research goes with a biphase linear regression model, which involves two variables, like an XY, for instance, as opposed to the linear regression model. An example of this, for those that aren't as familiar with this, would be a biphase linear regression would say, hey, let's look at grams of protein consumed per kilogram of lean body mass, or even just based on relative to someone's weight. Once you have both of those two variables in, that's when you find very different results in this, and you do have a high level of statistical significant difference with respect to the protein requirements of an older population versus a younger one. So this same data that was used, to establish the RDA that we have now at 0.8, the same data can be used as soon as you get into an area of biphase linear regression that would generate 1 to 1.2 kilograms per day. So we're talking a 25 to 50% increase in protein requirements as soon as that statistical model is changed to account for total body weight, or even better, in the terms of making a bigger adjustment to these recommendations, lean body mass. So that's a little bit of the history. Again, the current RDA, it may not have been optimal to capture the needs for certain populations, right? Again, it was established for those, 97% of people over the age of 19. It's mostly based on nitrogen balance research, which is simple. You're just measuring how much nitrogen is consumed and how much nitrogen can be captured that's excreted from the body. And those are compared. And once someone is in nitrogen balance, it's considered that the protein that they're consuming is adequate. But that makes, a variety of assumptions that we can get into here in a little while. It doesn't really, though, look at the changes that may have occurred in lean body mass during that nitrogen balance study. And I think that's what we're really after here, is we got to support lean body mass. It does not account for the oxidation of amino acids that are used or burned for energy. That happens. And it does not account as well, this RDA we're talking about doesn't account for certain protein sources that are just not as effective at supporting or preventing the catabolism of lean body mass. An example of that would be our branch chain amino acids, leucine, isoleucine, valine. Those are really much more effective at preventing the breakdown of skeletal muscle with aging, during exercise, you name it. And then, there's what we call indicator of amino acid oxidation, and that would suggest that there's a much higher protein requirement for everybody, but especially older adults, meaning that so much of the protein we eat is ultimately used to produce energy, that this alone should increase our protein requirements. And are we talking about, with this RDA, minimal intake versus optimal? Right, so these are all things for us to consider. And going forward, I think that there's more and more research will be devoted to these areas, and it is currently, again, there's compelling evidence that older adults, may in fact need considerably more. So here are some concerns, I guess, that people have had historically about protein consumption. There was, I think just a couple of years ago, there was an article in New York Times about how Americans were eating way too much protein, and that the average American was eating, 75 to 81 grams of protein. If you take a look at some of these numbers and the amount that's required, especially in those over the age of 65, I would argue that 75 grams might not be enough for a large percentage of Americans. But that being said, the World Health Organization, as well as the IOM, or the Institute of Medicine, they have both come to the conclusion that protein consumption, even at much higher levels than the current RDA, it's not responsible for a decline in kidney function or renal disease. And the World Health Organization goes on and they'll say that protein restriction happens with the aging process because the elderly typically just eat significantly less protein, often less than they really need, and that in fact that is what causes a decrease in their GFR, or glomerular filtration rate, and it's a natural consequence of decreased protein intake. It's not that it is causing a deterioration of kidney function in the elderly. So, again, this is I think this is an area that many clinicians have concern around still, is that at what point does protein consumption start to affect the kidney function or the renal health of my patient? And that's been over the years. This is, I would say, debunked to a large extent, that you have to get in areas of greater than 25, greater than, some would suggest even greater than 27% of calories from protein, which is much larger than what we're talking about here in terms of modest adjustments in the RDA. So again, protein consumption, even at much higher levels than the RDA, even if you were to double the RDA, even if you were to possibly triple the RDA, it's not going to be responsible for a loss of kidney function or renal disease. Now, the loss of functionality in not just in muscle mass, but also in bone mass. So it's coming from a couple different areas physiologically. Inadequate intake of protein. Okay, yeah, bang. That's a big one that we're really focused on. A reduced ability to use the protein that is absorbed. That is an integral part of this. I've mentioned insulin resistance and how that can really block the body's use of protein, amino acid transport. We know that there's a decrease in mTOR activity. mTOR is blocked during the aging process. That's a big part of this. There's also a block in nitric oxide synthetase and its ability to vasodilate or help with the perfusion of nutrients into muscle. So all of these things are happening simultaneously that cause a loss of functionality. And when we start to look at these are just a handful of papers here over the last 15 to 20 years that have taken a look at the current protein recommendations for older adults and what their recommendations are. And these, these researchers are all experts in the area of either gerontology and macronutrient metabolism, or in protein metabolism. And you can look through their recommendations and see what they largely come to as a conclusion here. And I'd say that you have some that are like the Wolf paper of 2012, which says that, look, there's no, at that time, there was no, real discernible differences in the populations that they had looked at. But because there are possible beneficial effects, and we know that there's a change in physiology with the aging process, that it's logical to recommend a level higher than 0.8 grams, per kilogram of body weight. And then you have those, that would say, like the Morley 2010 paper, that we should be upwards of 1.5 grams per kilogram of body weight. Now, based on their observations and what the work that they had done in their research. And it can become more specified when we get into other areas. So these are more general, but we're talking about adults with illness. So with illness, right, there's more inflammation, and we know that inflammation blocks some of those important physiological processes that allow us to absorb and assimilate amino acids into skeletal muscle and to improve bone density. And you can see that the recommendations are slightly higher, and that the convictions based on their observations and their studies are, are more significant. Like the Wells paper of 2012, almost 900 critically ill patients, those that did receive the recommended, the predefined protein and energy targets, they experienced nearly a 50% decline in the 1 month mortality compared to those that got less protein, not being under the RDA, but being less than the 1.2 that they had established in their research. So again, very, very very significant differences, especially once you start getting into different types of illnesses or conditions. And then when we get into hip fractures and osteoporosis, I think this is what's most surprising to clinicians in my experience in speaking to different groups and working with clinicians, is that there's an idea out there that if we eat too much protein, that it makes our bones frail, when the evidence is actually to the contrary, suggesting that if we don't get enough protein, and in fact if we just consume the RDA, that it may not be adequate for optimal protein intake. And I like the Meng paper from 2009, which is the third from the bottom. It's a 5-year follow-up, so that's one of the reasons I really like it. It's a 5-year follow-up, and they looked at 1.6 grams of protein per kilogram of body weight. Okay, not lean body mass, but body weight. So again, I think lean body mass is ideal, but they're at least looking at 1.6 versus 0.85, and they found that in a 5-year follow-up here, we had higher bone mineral density in the group that was basically receiving almost twice the protein per day. So there's really so many different ways to look at this. You can go macro with just looking at older adults. You can really start to target in on certain populations. Now, this study, it's important to note that this study, the Framingham Heart Study, obviously was not designed to look at protein intake and then measure hazard ratios, right? The Framingham Heart Study was obviously, it started in the 1940s, and it was to really look at different parameters of cardiovascular disease. So it's important to note that. But this is like a offshoot of that study. It's called the Framingham Heart Study Offspring Cohort. And in this, the researchers observed that the population consuming the most protein, you can see here over 90, 91, 92 grams per day, they had, in comparison to the participants, and we're looking at, in terms of person years, 9,600, 10,000, we've got a significant sample size here. But those that were consuming more around 91, 92 grams of protein a day, they had a 0.7 hazard ratio compared to 0.9 at 74, 75 grams per day. When you get down to 64.4, and look, 64 is considered the RDA for a 180-pound person. I mean, I weigh 181 pounds, roughly 81 kilograms. And if I follow the RDA, I should consume 64 grams of protein per day. And I can tell you without any doubt that if I were to only consume 64 grams of protein per day, I will lose lean body mass. Now, again, that's N equals 1. That's my own experience, but this suggests the same, in a different way, because this is looking at hazard ratios, and it's saying that there's a significant difference for those getting, in excess of 90 grams, 91 grams per day compared to those getting 64 grams per day. And we don't know, again, there are limitations of this study. Again, this isn't a double-blinded, clinically controlled, randomized study or anything like that, but this still has, I think, enough person years involved and enough, years of follow-up that it does carry weight. And so I like to look at things like this, as well as this is a geriatrics, Journal of American Geriatric study. This is 2018, also looking at mortality. And this is in a much older population. Now we're looking at ages 85 and over, and we're looking at mobility score first. as it relates to protein intake. And you can see that there's a much, much higher level of mobility at any given age with higher protein intake. So mobility, hazard ratios, bone mineral density, there's a lot of different ways we can look at the influence that higher levels of protein consumption has on an older population or on a critically ill population. This is a paper that, I think at first suggested that there may be some significant differences between men and women in their responses to protein consumed. And it suggested that, women may in fact have less of a response to a protein-rich meal, or possibly to the amount of protein consumed over a window of time. And again, it raised a lot of questions about differences at any given age. And Elena Volpe, who I mentioned earlier, she's considered one of the foremost experts on protein metabolism. She's at the University of Texas. She's published, over 60 papers on protein metabolism in different populations and the influences. What she's basically came to the conclusion, along with, Markovsky, is that once you take out, some of the differences, like during menopause, in particular, you start taking out some of the hormonal influences that can occur, that there really aren't the differences are not that significant, but there are times in a woman's body where hormonal shifts may alter their response to protein, how their body utilizes protein, and their overall protein requirements. But this is an area where I think, certainly more research is needed. I don't think this one is clear. It's obvious that androgens, as I mentioned earlier, estrogen, testosterone, those play a huge role in protein utilization. And obviously, during a woman's life cycle, those hormone levels will change dramatically, as they will in men, for that matter. So, we know that hormones play an integral part of this, and that may be a complicating factor in trying to pull apart some of the data that comes out of this research we're talking about. On the micro level, I've mentioned that, you need exercise to stimulate protein synthesis. And I'm really talking about both bone mineralization and all of the protein that's at the core of bone, the tropocollagen helix, so to speak, as well as skeletal muscle and overall organ reserve made up of, protein. You need exercise. It's really important to have that mTOR process, which is kind of at the center here of this slide. And you need to have, amino acids transported across the cell wall, the muscle cell wall. So a lot of things have to happen. And as folks get older, this is one of those kind of core learning objectives that I had set out for us today. As populations grow older, the mTOR process gets blocked. The use of nitric oxide gets blocked. And it becomes much harder for several of these steps to take place. So that results in decreased protein synthesis. But there is a growing body of evidence. We're probably not to a point where it's going to be considered empirical. But if you speak with, again, protein experts like Elena Volpe and others, they feel very strong that the research suggests 30 grams of protein is what's required to override some of the limitations of anabolism in an older adult. Again, I'm going to use age 60 and over. That sarcopenia it's a massive problem now. The RDA prevents deficiency in a younger population, but it's probably not adequate to promote optimal health in an older population. And that muscle protein synthesis, that's what the MPS stands for here in the third point, that MPS, to get that in an older adult, the amount of protein consumed at a meal or at one time is more important than the amount consumed by the end of the day. Again, these are just important points, I think, that we need to consider going forward. And so the author's conclusion are that 30 grams, maybe 25 grams, maybe as a sidebar, maybe 25 grams is adequate in some older adults, but 30 grams is what has been observed as a minimum for most of the adults, older adults that they've looked at, is what was required to stimulate muscle protein synthesis. And I think this is I call it a landmark paper because we know in the area of sports nutrition, for instance, that there is an optimal window of recovery. And that's when athletes who have been involved in any kind of strength training where you create tiny tears in the myofibrils, the functional unit of a muscle, to really optimize recovery and to get recovery happening at an accelerated rate, that the timing of when protein is consumed is important. And it appears that the same is true here with older adults. So what has been shown here is if you take the typical inadequate protein distribution over the course of a day, looks something like this. It's on the right here. And I think a lot of us can relate to that either in our own life or with the clients that we work with, right? Breakfast might be light. Protein might be, again, something that's eaten on the go. And then when folks do get a chance to sit down and eat more of a square, kind of well-rounded meal, all the protein, for the most part, or not all of it, but I'm going to say, more than 50% of the protein is consumed at that evening meal. And the authors, look at this closely and say, what, that just doesn't work to have that one meal a day that's stimulating protein synthesis, that the adequate protein distribution, again, same amount of protein, we're still talking about 90 grams, that has to happen over the course of the 3 meals. Now, obviously 2 meals would be better than 1, but if you had 3 meals where 30 grams of protein was being consumed, that's going to be much more effective at mitigating the presence or the development of sarcopenia. So again, really compelling arguments being made here about the amount of protein consumed at one time as opposed to what's spread out in smaller amounts over the course of a day, or that's all basically end loaded at that one evening meal. So the consensus here, again, going back to 2006, again, this is looking at a variety of different studies that include meta-analysis, follow-up cohort studies, looking at things that, just really, whether it's bone mineralization, recovery from thoracic surgery, hip fracture recovery, looking at it just an all-out, reduction in mortality, hazard ratios, and looking at this from so many different angles that really there is a compelling argument being made now that many populations need more protein than the current recommendations to have an optimal recovery, and that this 0.8 grams per kilogram of body mass, it might be adequate for younger adults who don't have any of those physiological impairments yet with respect to muscle protein synthesis at the blood vessel level, at the muscle membrane level, with respect to IGF-1 or insulin levels, that it's, we really need to look at this much more closely and think about our patients maybe in a different way. So we need more research in this area to define the how, the who, and the what, for that matter. What's the best way to really ameliorate, bone loss and muscle loss? But the questions, I think, that are going to be delved into further here as we go forward are, is the 25 to 30 grams, is that in fact what Elena Volpe and others have shown? Is that the case? Certainly would seem that way. When protein consumption is spread out in small quantities, over the course of a day, does in an older population, does that in essence get washed out and have, less of an effect on the ability to synthesize new proteins? And again, in a couple of weeks, we're going to talk about specific amino acids like the branch chain amino acids and others like arginine that play, very unique physiological roles, not only in protein synthesis, but also in helping with blood flow and circulation in the case of arginine, and influencing our immune system in certain ways. So we're going to delve into the qualitative look at this, but I think that is going to be intertwined with this conversation around protein recommendations and what it is we advise our patient and the populations that we're working with to aim for as a target, not only at the end of the day, but at the end of the meal. And I think that this is great, because I think it's going to help all of us as clinicians gain a new insight and develop a new way of assessing true protein requirements that take into account a variety of factors that typically are not, from the micro level, to the macro, looking at just a person's age or their lean body mass versus total body weight. And that's, I think that's an important question, because does body weight really reflect a patient's needs? I mean, obviously organs and what we call collectively organ reserve, which is all of a person's lean body mass, that is what ultimately requires the protein and the amino acids for structure, for repair, recovery. But body fat, that does not. And unfortunately, we have, a large population where total body weight is very different than lean body mass, and it can really skew things. And it definitely skews the research, because if you have somebody that is obese with a much smaller amount of lean body mass, well then, changing, if those subjects are included in research, you're not going to see a significant change in any facet of their physiology when they're given or they're consuming more protein, because they actually have a much lower protein requirement than one would think based on total body weight. So it's very complicated, but I learned in my exercise physiology courses, 30 years ago, and in the area of sports nutrition, that you really want to tailor protein requirements based on an athlete's lean body mass, because you get right to the point. You get what is accurately and really required for optimal recovery. And so I think it makes sense that we have to look at this for a critically ill patient as well. So the implications of this and those questions, in summary, that we really want to continue to ask, and we should continue to read and look at the research that is forthcoming in these areas, is can the RDAs be reestablished for those over the age of 70 to 1.2 to 1.5 grams per kilogram of body weight, as many researchers suggest? Should most populations, instead of looking at grams of protein per kilogram of body weight, should it change? Should we start developing RDAs based on lean body mass? And that number would jump, obviously it could jump substantially. Should those folks with osteopenia or osteoporosis, instead of being advised to reduce their protein intake, to be careful around protein intake, should they actually receive a very different message, which is you really got to focus on getting more protein along with your calcium and bone building minerals and vitamin D. There's a compelling argument that more protein is much more protective against further bone loss. And should surgery, patients, those who have undergone thoracic surgery or have had any kind of major surgery, should they be getting at minimum 1.5 grams per kilogram of body weight? And I think lastly, that, the real big question here is 30 grams per meal, 30 grams per meal. Is that more effective than any amount per day? And I think that if you look at, a few of those studies more closely that I've shared with you today, I think it would be very easy to say, yeah, wow, we should see some more studies in this area. But it certainly is, again, it's a compelling argument that is the case. And in summary of how we look at our patients, as I've talked about here, these are some very important factors to take into consideration. Obviously, age, as well as how much lean body mass has been lost, if it's possible to determine that. That is something that is not done very often clinically. It requires, some form of first capturing lean body mass, whether that's at a baseline or at some type of, exit assessment. But, lean body mass is calculated typically if you're you're in a hospital room or you're in a clinic, it's done with skin calipers. That takes a trained technician. Bioelectrical impedance can be done in some settings. It's not always available. Certainly none of our patients are going to undergo hydrostatic densiometry, because that's really only done in research and exercise physiology. So in the end, I mean, skin fold caliper tests are not done very often. DEXA scans, which are often used to determine bone density, are sometimes used, but they're also not typically involved. So, this is a tricky one, because I don't know as though we very often have an assessment of a patient's true lean body mass. But that being said, it's not something that I think we should lose sight of, because I think it does have a role to be, really better serving our patients in terms of coming up with a protein recommendation. Have they undergone, major surgery? Is there insulin resistance present? And I would say, unfortunately, that for most U.S. adults, the evidence suggests that there is some. More than half of U.S. adults have, some level of insulin resistance, if you look at, the data that's out there. What clinical observations must be made to focus on, how a patient responds to different types of dietary proteins? Type is important. We're going to talk about that in a couple of weeks. But, if you have a loss of digestive function, then it's going to be very difficult for a patient to adequately break down protein to a point where it can be used for assimilating, new lean body mass. And that's where the role of peptides comes in, or, some type of pre-digested hydrolyzed form of protein to really help reduce, that barrier. And then how can we measure a patient's gains in lean body mass as opposed to overall body weight? This is follow-up assessment. And then I think our assessment as registered dietitians, and, again, it's Registered Dietitian Day, National Registered Dietitian Day. So I want to say thank you to all the RDs that are with us today. As a registered dietitian, how is it we can best assess the nutrition habits, practices, or records of our patient? And I think it's important to look at how much protein is eaten at each meal. Is a patient missing, a couple meals a day, or only getting, 5 to 10 grams at 2 meals, and it's all at 1 meal, as we discussed, as opposed to just looking at the overall daily amount. And then, as I said before, sources of protein can really make a big difference, because we know that not all sources of protein are created equally. But this shows a change in fat-free mass, and weight gain, weight loss, and sometimes you can have a significant gain in weight, which is the blue or purple line here, and you will only have a subtle difference in what we call a gain in our fat-free mass. But this is what has to be taken into account. And this paper really looks at the differences in protein recommendations and the effects that it has in typical free living populations. But quantitatively, I want to say that, in summary here, specific populations have unique challenges in place that can really alter their protein requirements. Catabolism, which is a more generic term in the area of metabolism, just describes a loss of lean body mass, and we know that a lot of patients undergo that with any type of, even in modest length stays. We don't have to get into long-term hospital stays or long-term stays in an ICU. It can happen even in 1 to 2 week stays. There can be a significant loss in lean body mass, and it's not always a function of that they're just not being provided with enough protein. It's that their metabolic rates are altered so dramatically that they need much more protein than they would if they were at home. The amino acid content and contributions that each of those make to muscle growth it's higher levels of efficacy with different amino acid contents. And that brings us to plant protein sources will always require multiple plant sources of protein to reach biological values that we know are associated with protein efficacy or good use by the body. So, anytime there's a product out there that only has one plant protein in it, if it only has, let's say, pea protein, and you don't see any complementary sources of protein involved in that food, it's safe to say that it is not a complete protein and that it's missing important essential amino acids, and it's not going to have the same effect on stimulating or helping support muscle protein synthesis or any area of lean body mass. And, again, we've gone over a lot of these. We know bone loss is integrally tied to this. There are several different ways we have to look at a patient's facets of life, variables, quality of health, and what they're experiencing before we come up with a more accurate or tailored protein recommendation for them. But we need to question the current RDA of 0.8, and we really need to question that, most importantly, for older adults, for those that have had major surgery, bone breaks, or fractures, and those who have had, at least modest stays in a clinical setting, ICU type setting, because we know the evidence suggests that they'll benefit from a higher level of protein if we can get it to them. And so with that, I really look forward to any questions you might have on this topic.
Thank you, John. That was a great review. And as John said, happy Dietitian Day to all the dietitians out there. We're so grateful that you joined us. And just a couple of announcements. The CE credit is pending CDR approval. So as soon as we know or have that, you will be notified and we'll send that out. And the recording will be able to be accessed on the website next week. The slides will not be shared, but you will get a list of the references. And again, you'll have the recording available next week. So there's lots of great questions, and I know there's a part 2 coming up. So some of these will be addressed then, but we'll dive in for the last 10 minutes or so to cover some of these. And a lot of questions, John, revolved around how to assess protein just for different weights and BMIs, considering first if someone's has a BMI of greater than 35 or 50. So if you are, how do you calculate protein requirements, and if their protein requirements are extremely high, given that considered like 200 grams or greater, how do you suggest that people meet those amounts? Especially if they're vegetarian and have trouble getting that same amount of intake?
Yeah, hey, that's a great question. And it does become, again, as I mentioned earlier, when we start to attempt to separate lean body mass or to identify that as opposed to total body weight, it's really difficult. Again, with my background in exercise physiology, taking so many graduate courses in that, it does take a very skilled and trained clinician to effectively use skin calipers, even at lower body mass indexes. When you get up above 35%, there's a huge amount of standard deviation and error of that compared to the gold standard of measuring body mass index, which is essentially underwater weighing, or the hydrostatic densiometry that I measured. So I would say that if a clinic, if you have access to a DEXA, obviously it would be tough to get that maybe covered as part of that patient's care, but I think it is certainly warranted if you have use of dual X-ray anthropometric measurements, which are used for measuring bone mass, and you could use that to get an accurate measurement on a patient's body fat percentage, and then that would be subtracted from their total body weight to come up with their lean body mass, and that would be done in kilograms, and then that could be used based on the patient's age to come up with a more accurate recommendation. So I'll just use, let's say someone had a BMI of 50%. If a body mass index was at 50%, theoretically, that person may, even though they might weigh 200 pounds, they may only have 100 kilograms of lean body mass, and that's going to give them a very, very different protein requirement. I think that that's important. Now, I will say I don't want people to consume more than 200 grams of protein per day. I got that in that question. I think that is, you're starting to approach a level that I would be concerned about. Not that it's going to necessarily, damage their kidneys or their renal system, but then I do worry to some extent about the potential renal acid load. Not that it's going to damage their kidneys, but that it's going to have some acidosis-like effects on them. So, 200 grams of protein is a lot of protein, and I don't think there's anybody out there that really warrants that kind of intake. I would say that if someone's a vegetarian and they have a high BMI, I'm going to try to answer this question. It's a complicated question, but if a BMI of 35 to 50%, I would say that, those patients will do very well, typically with anywhere from, again, 85 to 100 grams of protein per day, plant protein, but it's going to have to come from multiple sources, which means you have to put like pea protein with rice protein or with rice to get a complete protein, or you have to put, again, there are a lot of different choices out there, right? I mean, you could put soy protein with another form of another plant protein. We know that certain green leafy vegetables, for instance, will round out or complete the proteins from things like, quinoa. I mean, so it's, again, you just have to combine, and we're going to get into that in 2 weeks. But I would say, in summary, a patient that has a really high body mass index, again, 35, 50%, when you start getting into that areas, I would want to have them, typically somewhere between 85 and 100 grams per day. I wouldn't want them to go over that because, again, it's all about lean body mass, and we know that that they, have a significant percentage of their total weight that's tied up in fat mass that you just don't really want to deliver protein to. But it's hard to get an accurate number once you get above 35%. So that's where you start to have to use, I think, estimates.
And similar weight related, if someone is underweight, is it better to, and they require more protein, is it better to eat 30 grams per meal for 3 meals a day, or and increase the protein from 30 grams, or add a fourth meal where they're aiming for 30 grams?
Yeah, that's a really common question that I do get. I think there are certain individuals or populations, I should say, that either due to their physical workload, typically athletes that are in training, we know that they often warrant a fourth meal per day. And I would go so far as to say that, yes, you have a number of, compromised in terms of their health. Clinically, you have patients that are going to need that fourth meal as well. You want to try to allow 4 hours, 4 to 5 hours. 5 hours would be ideal in between these meals. So that means an early meal followed, at the end of the day by a late meal. But you got to have optimally 5 hours in between these. So it would be between these, 4 meals. You got 3 windows there that would have to be 4 to 5 hours long. I think that spacing is really important. But yes, I would say someone who's had a really significant loss in lean body mass, and I often describe these patients as cachexic. Those are the folks that are going to need that fourth meal. 30 grams is the minimum that Elena Volpe and others that have really looked at the timing and the amount per meal. 30 is the minimum. I would say that you don't want to really go over 45 grams per meal. The reason I say that is, 45 grams, you start to get into an area where there's definitely a limit to how much of the protein that's consumed at one meal can be effectively or efficiently metabolized into the body's proteins that need to be assimilated. And once you start getting beyond 45 grams, again, some of this research goes back into the 1980s, 1990s. Definitely, there's a law of diminishing returns when it comes to how much protein is consumed at one meal. When you get up in that, 40, 45, I put a limit at 45 grams per meal. But I think some patients could definitely do better with 40 grams per meal as opposed to 30. I think it has a lot to do with their lean body mass, as well as what it is they're experiencing in terms of a condition. Or I know with athletes, for instance, if you have an athlete that is training, 3 hours or more per day, they have to have 4 meals per day. They have to have that 25 to 30 grams of protein at each of those meals. And I think for a larger athlete with a high level of lean body mass, like some professional athletes that I've worked with, they need that full 40 grams of protein per meal 4 times a day. And that's to stay at their current lean body mass. When they want to gain muscle mass on top of that, it's very, very difficult. But yes, I think 4 meals is often warranted. And I think more than 30 grams, I think is often required as well.
Okay, and I know we're at 1 o'clock, so I'll do one last question since it seems like there's a lot of clinical folks that are in that work with chronic kidney disease. So I know you spoke to higher protein needs and that it doesn't impact kidney function, but if someone does have chronic kidney disease, how do you address their protein needs, since it's commonly told to lower protein with those in that patient population?
Well, yes. I mean, that is absolutely true and important, is to limit that protein. I mean, when someone already has renal disease, that's a very different situation. I think the point I was trying to make, obviously, is that higher protein intake is not responsible for that renal disease, which is often the way it's perceived. But if a patient, or for those folks that do have renal disease, impaired glomerular filtration rates, that type of situation, you really do want to try to limit the amount of protein per day to around 0.7 to no more than the 0.8 grams. That 0.8 grams per kilogram of body weight is still, typically it's well tolerated in renal patients. It is spread out over the course of the day. We know that a lot of our renal patients do lose lean body mass, and it's unfortunately, I just don't know of a way around that. I always emphasize for renal patients the importance of plant protein, because plant protein, and it's not always the case, but many plant proteins, but I would, to be fair, whey protein is also going to be in the same category. Often they come in foods that have markedly lower PRAL values. And when I say that word PRAL, I know I've mentioned it a few times, you can look into this. It stands for potential renal acid load. That's PRAL. And the USDA actually has a PRAL or PRAL table for many of our most commonly consumed foods, especially protein-rich foods, that can be used by nephrologists and others that are involved in the area of renal research. I think it's really important to stick with lower PRAL values whenever possible, to reduce the burden or the stress on our kidneys, and with a renal patient. And you definitely are going to limit protein, to around the 0.7, 0.8 grams per kilogram of body weight. I know that there are nephrologists that recommend even greater restrictions, and I think that those I'm not obviously a nephrologist, and those may be warranted depending on the level of disease. But it is an important factor to take into account. But I really recommend that renal patients get more of their protein from the less acid-loaded foods, which are those which contain, again, very high levels of protein and very low levels of things like calcium, potassium, magnesium to a lesser extent.
All right. Well, thank you so much, John. And I know there were many questions, but reminder that there is a part 2 to this, so many of those will be addressed, and that webinar will be on March 30th. An invitation to register for that event will be sent out next week on March 16th. And reminder, again, you can access this recording on the new Functional Formularies website in the clinicians section. So we're so grateful for all of you being here. Thank you, John, again, for such a great review, and happy Dietitian Day to all.
Thank you, Catherine. Be well, everyone.
Bye.